It is always fun to be here, and this is an interesting topic for anyone who was here last year. There's also some updates in terms of the spin, some of the context of it, but maybe at the core, very similar advice about exercise. I'll give you, the sneak preview is that overall there's been a lot of, I think, misinformation or misperception, anecdotal stuff that goes around about exercise and its benefits or risks for people with ALS. And overall, we think it's a beneficial thing, just like with anyone else. And I think the onus is really to prove that it's unsafe. That's my kind of approach coming into it. And then we have some data to back up that approach. So I'll talk a little bit about some of the history and the current views about exercise for people with motor neuron disease and some of the things that shape these kind of views in terms of the things happening, really particularly with athletes. And then we'll get into some of the basics of the MSK system, as well as talk about just how to prescribe exercise for these patients. So it's no wonder that we kind of are concerned about the relationship between physical activity and this disease. It's named after one of the most famous athletes of his time, Lou Gehrig, who, amongst other accomplishments in baseball, was known for his durability and just, prior to Cal Ripken playing the most consecutive games without missing a game. So pushing his body to the limits. And not that it's necessarily directly related to that, but you can kind of see this plot I took out of a textbook of rehab medicine on ALS, where you can see his batting average over time, and then incredibly, one is excellent, being around 350, and then a drop off, and then his final season. And you can see that maybe there was a decline even prior to that. You tend not to pick up on these declines with daily activities, but when someone's performing at this high a level, or I can't tell you how many people come in and tell me that they noticed something was off because they were a cyclist or working out in the gym and something was different. But it's hard to pinpoint, and we do a bad job because our clinical exam isn't going to necessarily detect that type of dysfunction at bedside. And to kind of pile on, a lot of the people we think about who have ALS, Steve Gleason, in Canada, where I'm from, Tony Proudfoot, who was with the Alouettes in Montreal, and then of course with the Ice Bucket Challenge, Pete Frates, who was a pitcher at Boston College. So you see all these anecdotes and you wonder about it, but fortunately most of us aren't college or professional athletes, so we're maybe not worried for our own kind of self. But what about if it just being active is the problem? That could apply to a lot of us, and I can tell you that the cross-section of people we see in the clinic is not the same cross-section we see in our general neuromuscular clinics. The patients look different. They look different than probably the average population when they come in. They tend to be more, on average, more fit and leaner and have been high-performing in some aspect of life, whether it's athletics or otherwise professionally. So there is something to that, speaking more anecdotally. But I don't think the data really backs up that being physically active itself is a risk. And there was some early epidemiological data that created some concern about this. I think the trend has been more with larger studies that physical activity by itself isn't a great explanation, and it's certainly not convincing as a risk factor for ALS by itself. And a more recent review kind of summed it up, and I actually have just published a paper, and I looked at this after I put ours together that came out this year, but they were out before us, that not only was it not generally a risk in the general population, but there was a consideration here that some occupation and some athletic activities may be higher risk, and that is harder because it gets into smaller stratifications and trying to get a little bit more precise. And statistics work really good when you have a lot of people, and then when you get into really small categories, it gets a little bit trickier. That doesn't mean it's not true, though. And so there's this really provocative result that came out of the group at Boston University. Ann McKee, I think, who's well known for the NFL work, and Bob Cantu, who with the CTE, the chronic traumatic encephalopathy work that they've done there, and has really influenced our view of sports and concussions. And the link to ALS and motor neuron disease with that work came some more recent papers where they've reported these cohorts of 85 patients that they've screened who had a history of concussion or mild traumatic brain injury, which I think the language is not to use so much concussion anymore, but to call it a traumatic brain injury that's mild. And the group here was selected. I mean, it was athletes who played contact sports, military veterans. It wasn't your general population or anyone else who acquired a concussion in another fashion or mild TBI. And out of the 85, 68 of them had this neuropathological evidence, because these were all people who donated their brains for study, of the chronic traumatic encephalopathy. 8 of them had a motor neuron disease. Whether we call that ALS or not, it's unclear. But it's way overrepresented in this group. And so in the paper that, we had just recently published a review on looking at this, because we've been interested in trying to get at the mechanism a little bit more in the lab. But we spent a lot of time doing the kind of a reverse translation, sort of thinking on it, what's happening, what are we seeing in clinic, and then taking that back to our research. And, I won't get into the details of like kind of some of the pathophysiology and the neuroanatomy connections that we were sort of discussing with the linkage between the upper motor neuron and the brain injury, the lower motor neuron and the spinal cord, which of course are the 2 cells affected in ALS, as we would have learned earlier today, and how that plays a role in terms of potentially setting you up with exposure to trauma and then high levels of activity for developing neurodegeneration. And it wasn't just ALS in that paper. There was some linked to Parkinson's disease and Alzheimer's. But I guess the way that we're our working kind of model of what might link this is really a genetic trauma interaction, which is hard to put your finger on right now, but we're kind of in the personalized medicine, genetic medicine revolution, and it's going to change the way that we kind of give advice to people. But you can imagine one person coming in who has a genetic kind of profile that makes them more resilient to disease, getting exposed to trauma and high levels of activity and maintaining good motor neuron health here in the top. And then a second person who has the same exposures but more vulnerable based on personal factors such as their genetics, and then develops motor neuron degeneration. So at this point, this is more of a model, but it is something to think about, because this is getting at the root of why there was even a controversy to prescribe exercise to begin with, is because of these sort of anecdotes. And so anecdotal medicine now, with our ability to do more patient-specific disease modeling with stem cells or genetic studies, is something that we can probably address better than ever before. But it's not ready to change the way we practice medicine, at least not in the ALS clinic. So I'm not going to change my advice about activity based on this. You could argue that if you came to me and talked about participating in head contact sports and doing it at a high level, and I was in a primary care or pediatric practice, maybe there's enough to create some, based on precautionary principles, some advice that you would give to younger athletes, but not in our clinic. And certainly it doesn't seem that the activity by itself was the problem, from what we can see so far. So that's sort of getting back into that sort of historical kind of perspective, I think, that shaped our views on it. To now getting into just an overview of exercise and what's involved. So just coming back to that picture, at least it highlights some of the key components of the nervous system and the muscles and MSK system, so your bones and your tendons and so forth, that determine your ability to perform exercises. And there's factors, different ways of viewing it, the things that are sort of intrinsic to your system, and then the things that are external to it that can influence how we prescribe exercise. There's things that are more modifiable than others too, I'll come to in a second. But things like the muscle shape, the angle of the fibers, how trained you are, your ability to kind of have a good recruitment pattern, which is one of the earliest adaptations to exercise, isn't changing the size of the muscle, but it's changing the way that we activate it. There's also things that we definitely can't control, like where your tendon would insert on a bony landmark, and what's your lever arm, and those mechanics, and certain inherited or pathological conditions that we can't control, as opposed to things like trauma or acquired disease that may be more related to things that we're exposed to. And then just also when someone comes in, are they in already a deconditioned state of disuse, or have they been training? What's their sort of functional reserve, if you will, when they come in? So these are all things that we have to take into consideration when we're giving these advice. And like I said, what can we do about the non-modifiables in terms of, so those aren't the things really to focus on in terms of those factors, but the things that we can change and think about changing these patients and whether or not it's appropriate. I mean, most of us, and the sort of the standard has been more stretching range of motion, preventing contracture, and some of the disuse syndrome. When you think about things like muscle length, that also can mean when you do exercises and prescribe exercise that you would want to prescribe an exercise to operate through the whole functional range of motion and not just a restricted part of that motion in order to get the maximum translation into an activity that you're, and that sort of gets at the specificity of training. Not something I spend a lot of time thinking about clinically, but it is bread and butter exercise physiology. There's things like the muscle cross-sectional area. So unlike Arnold Schwarzenegger would have been the example when I was in university, him and I would have the same number of muscle fibers, but each individual fiber that he has is bigger. So we don't increase the number of muscle fiber that we have, we just increase the size of them or the cross-sectional area. And that can be viewed at the whole muscle level or on the individual fiber. And we can actually have a pretty dramatic and rapid change to the size of muscle with just a little bit of disuse. So we know this from studies that you couldn't do today where you put people into bed, rest, and make them stay like that for a week or two. And this was done in the 40s and 50s and people who were in the military and so forth. And so this is actually, if anything, probably this rate of disuse based on those studies probably underestimates how quickly the disuse would kick in a more frail person or someone who's older. And then we also have, as far as the output of motor units, and I'll say about the neural drive, one thing to think about specific to ALS is, well, this is an early training adaptation, but ALS motor units are kind of different because usually by the time we're diagnosing them clinically, you have a lot fewer. And so you get into this issue that I don't think contributes to fatigue in most of us, but in an ALS patient in a weakened muscle, they have fewer motor neurons that are powering the muscle. So instead of just having muscle fatigue, the buildup of lactate or however muscle fatigue works, which is actually, it opens a whole can of worms, but you actually can have what we think is central fatigue because the same subset of neurons are firing repeatedly at a higher rate, like in the top tracing where you have fewer waveforms, and then a normal muscle where with a bit of effort, you can fill up the whole screen with different waveforms that indicate you have a lot of different motor connections. And they cycle in and out ordinarily, but in ALS, you're using the same ones over and over and over. Therefore, we think of feed forward in terms of their dysfunction is that you have fewer connections and that those connections are more at risk. So let's talk about how you approach exercise. Hopefully I'm doing okay for time. So I think the assumption we should all have, and I'll explain why with, I hope, a little data, is that exercise is good until proven otherwise. It doesn't mean that we push a lot of exercise onto every patient. You have to think about that, and I'll get to that in a second very carefully. But you shouldn't discourage patients who are interested in exercise, generally speaking, from pursuing activity. But you really do need to work with these people because some of the people that you're meeting in this clinic are not, they are like the Lou Gehrig's of our, like they're not the typical cross section. So you realize when they say that they want to do activity, they may be talking about something very extreme. So you do have to put the brakes on sometimes. So the general recommendations, these were just updated in 2018 for the U.S. population. 150 minutes a week, 2.5 hours of time spending on aerobic exercise per week. That's 30 minutes, 5 days a week or something like this. It can be broken up in different allotments. It can be moderate or high intensity. I emphasize moderate certainly as the starting point for getting someone into an exercise program. And that's actually going to be where we park our patients with ALS. Generally speaking, we're not really going for the highest levels of intensity. Does anyone know, when you're talking about cardiovascular or resistive exercise, what is moderate? What would be something, there's a little gray, but ballpark, like what are we talking about? How would you define it? There's subjective, you can have objective criteria. What was that? Perfect, yeah. Relative perceived exertion, the Borg scale. You have a scale, it's actually like 6 to 20 is the original scale, which roughly lets you predict heart rate based on where they put themselves, which is neat as well. So that's why it starts at 6 instead of 0. You can also do that scale in 0 to 10. And then heart rate based on your predicted, usually based on age is how we determine that, as opposed to actually doing the physiological testing, which is roughly your age, so 220, subtract your age as a starting point. But whoever you're sending someone to for guidance will be able to calculate that. So then what's actual moderate? So moderate is you're able to speak in short phrases, not necessarily a full sentence. Or if you're doing heart rate, you're in that 60 to 70%. When we talk about resistive training, a moderate would be being able to do like 15 to 20 reps, not failing at 10 or 12 or fewer reps when you reach that point where you can't do the next rep. Then the other two advice, like spending less time sitting or building up to 300 minutes, I'll put the caveat, this is where it really gets important to take these guidelines for the general population and think about how we do this in ALS. And the first thing, and Sabrina Paglioni, who's a neuromuscular trained physiatrist, similar to my background, who's at Harvard and Spalding Rehab in Boston, has a nice paper, so I'm stealing a little bit from her kind of approach, and which I agree with. The first thing is individualization. And individualization starts with, am I even going to bring this issue up and push it? You have to, a lot of times I wait for someone to bring it up to me and ask me for advice about how to use this, because I'm not going to go to everyone in the clinic. And you can imagine the age range of people who are affected with this disease. We're getting some people where just this doesn't really strike you as like where you want to spend your time talking about pushing an exercise program. But you have other people who are quite young who have been already doing exercise and sort of really motivated to maximize what they have left. Plus, our patients, maybe this is an example of a guy doing one-arm shoulder press compared to that two-arm. Maybe you have one arm that's not anti-gravity, so you can't even do that exercise. So being able to modify exercises appropriately requires a bit of specialized training. Like I said, the moderate intensity level, and then really focusing on a couple general rules that you don't want to be sore or worse off the next day after you do a program, and you really want to make sure that you focus your efforts on training parts of the body that can benefit. So usually as a rule, we say you have to be grade 3. In other words, you can move the limb anti-gravity, and we can have an exercise program for that. But if you just have a flicker or twitch, then that's probably not the right part of the body to focus your strengthening on. So I'm finished on just what we can say about safety and efficacy. And there's been 2 Cochrane reviews by the same person who did one of the 2 clinical trials. The 2 trials total 43 participants. So these are the highest quality exercise trials that have been done in ALS patients so far. There's 2 additional trials that will be included in a future Cochrane review, which we'll integrate those 2 trials. But the most recent update was this in 2012. And so there was 2 protocols looked at: a moderate load intensity resistive exercises, and then another, which is 27 people total. The 43 refers to how many actually got the exercise treatment. And in the other study, it was actually a moderate load endurance exercise. So we had 1 resistive, 1 endurance. So both of them, I can tell you that when you see these numbers, you know that there's not a lot of statistical power. In cardiovascular rehab studies, we're going to have thousands of patients enrolled. So here we're talking about dozens of patients. So that's one issue. However, I can report that there was a hint in these studies that there was an improvement in the functional rating scale for some of the motor categories in favor of exercise. There's no effect on survival that we've seen. We know that statistically that we're not powered to necessarily see In fact, we're at risk, in fact, of like making an error based on just not having enough patients that we could miss a real effect if there was one. But the most important thing I can reassure you is that there's no adverse effects in either of these two trials with this type of intensity, with these two types of programs. And so, and that goes for anything serious to things just that are a little bit more manageable, but still like would be problematic if we gave people muscle cramps or a lot of pain as a result. So exercise can be done, it can be done safely. The two new trials agree with that. In fact, there was one of the two trials also showed a hint at improvement of the motor subscale for ALS patients. Again, note these were still relatively small trials, but as you start amassing the data, I think the safety is what comes out the clearest. And what I'd really like to kind of take home is that we know that moderate exercise is and exercise is good for the general population. There's no reason to deprive this from our ALS patients. We do have to pick the patients appropriately. People who are going to have the, like Sharon, I think I was talking about, and Kristen and Sharon's talk about not pacing and not making someone use up all their energy on the exercise program and not being able to do daily activities. That requires a little bit of guidance from someone who's asking the right questions, hopefully in the clinic, and a therapist who has some experience. We definitely have many people who definitely feel better maintaining their activities level and are relieved when we tell them that they don't have to give it up. And we can tell them that it's safe and that there might be a hint that we improve motor function. We're not necessarily going to tell them that it's going to increase their lifespan. We're not going to make them feel bad if they can't participate either. They're not necessarily missing out on something that is, we can't tell them that they're going to do necessarily worse without the exercise, but for the right person, it can be a really important thing, and it has a lot of other benefits, quality of life and so forth. So I'll end on that note. Thank you for your attention. I think we covered the three main objectives fairly well, and hopefully gave you some useful advice to approach this topic, and not be afraid to tell people it's okay to exercise, but don't try to tell everyone and shove it down their throats either, okay?